Hi everyone, my name is Magar and I'm one of the R1s in medicine, and I'm presenting my poster titled "The Case of Biliary Strictures, Don't Be Narrow-Minded." So biliary strictures present a diagnostic challenge, and the stakes in achieving an early and accurate diagnosis are high. And this is actually particularly important in the setting of a septic obstruction or malignancy. Detailed history examination and imaging are important, but can be at times inconclusive. Um, Specifically, MRCP, which has been reported to have a very high sensitivity and specificity for diagnosing biliary disease as comparable to that of ERCP, is an important initial first start. But here I'll present a case of a patient who came in with severe jaundice that was caused by a dominant biliary stricture that was amenable to intervention that was only identified on ERCP and not found on MRCP. Um, so the case history, essentially 28-year-old male presenting with progressive jaundice, has a past history of PSC and UC. Essentially, this 2-week history of jaundice associated with the classic symptoms, pale stools, dark urine, and pruritus. There's no clear inciting trigger, no fevers or infectious symptoms, no abdominal pain. Notably, he had an MRCP from 3 months prior, which reported stable disease of his PSC with no dominant stricture or cholangiocarcinoma. His physical examination was largely unremarkable. Apart from being visibly jaundiced, he had no features to suggest cholangitis or liver decompensation. He was admitted to medicine for a further workup. In terms of his initial investigations, his T-bili on arrival was 302. He had some mildly elevated liver enzymes, and he had this new CA199 positivity. He had an abdominal ultrasound, which essentially showed no acute findings, and then had his MRCP, which again showed no significant interval change. There was no dominant stricture or obvious obstruction of the bile duct, and there was no cholangiocarcinoma. Unfortunately, this patient continued to have progressively worsening cholestatic jaundice throughout his admission, and his T-bili actually rose to above 475, and there was no clear explanation based on these imaging. So GI was consulted for consideration of an ERCP, given the diagnostic uncertainty. And on ERCP, it was actually found that there was a dominant extrahepatic stricture that went from the hepatic duct all the way to the ampulla. And there was significant proximal dilatation. And this patient underwent a sphincterotomy and a balloon dilatation with brushings that were taken and importantly came back negative for malignancy. And he clinically and biochemically improved. So I think the big learning point in this case is that, despite the relatively accurate imaging modalities at our disposal to evaluate biliary disease, including an MRCP, which has a reported sensitivity and specificity of 98%, some studies even up to 100%, I think there is still some diagnostic uncertainty which can be possible. And the decision to pursue ERCP may ought to be more clinically driven to prevent unwanted morbidity. We all know the increased risks and complications that come with an ERCP, um, but it is worth noting that a lot of the accuracy that is attributed to MRCP is specific to biliary obstruction, and this accuracy is actually reduced when evaluating for strictures and specific, and particularly when delineating between benign versus malignant strictures, which can have profound implications to patient care. And as we saw in this patient, MRCP didn't really identify a clear source for his symptoms, and ERCP did, and it was amenable to intervention, and he, gave a good clinical outcome as well. So thanks very much for listening.